So hi guys, welcome back to today's session. Good morning all of you, and I hope I'm audible and visible to you. And today we are going to talk about the rapid fire MCQs in surgery episode 2. So we just covered rapid fire MCQs in surgery episode 1, let's say around 1 hour back. It was scheduled at 9 a.m. If you want to check it out, you can definitely go and check it out. And yeah, here we are going to talk about the episode 2 of the same thing. Okay, so yeah, let's begin. Let's talk about today's stuff. Right. So without wasting any further time, let's start with the first question. The first question which I have for you guys is, which of the following statement about the hiatal hernia is false? Okay, so which of the following is false? Most common type is a sliding hiatus hernia. In sliding hiatus hernia, GE junction moves proximally. Cambrons also are associated with the sliding hiatus hernia, and the top it is a posterior 180-degree wrap. So what do you think, guys? What is the answer to this particular question? Okay, so this is a question which is basically based on the different types of the hiatus hernia. Now, if you say that the answer to this particular question is option number C, that is cambrons also, it is associated with sliding hiatus hernia. No guys, it is not. It is associated with the rolling, which is also referred to as the paraesophageal hiatus hernia. Then you are absolutely correct. So now let us evaluate what are the different types of the kind of hiatus hernia. So we have two main types of the hiatus hernia, right? So what do we have? We have the two main types of the hiatus hernia. We call it as a type 1 and we call it as a type 2. So type 1, this is also referred to as a sliding hiatus hernia. Okay, it is also called as a sliding hiatus hernia, and the type 2, this is also referred to as a rolling, which is also known as a paraesophageal. Okay, this is what we have. Now what is happening in the sliding hiatus hernia is that, let's say this is your esophagus and this is your stomach. What do you got? You got a gastroesophageal junction. You have a GE junction. Now I'm sure you must be knowing that this G junction is very important in order to prevent the reflux and all. So if at all due to some reason this GE junction moves proximally, okay, if at all this is displaced cranially, this is what is referred to as this is what is happening in the sliding hiatus hernia. In other words, the GE junction has kind of slided upwards. On the other hand, in the rolling or the paraesophageal hiatus hernia, what is happening? This is your esophagus, this is your stomach. So here the part of stomach is going into the thoracic cavity, okay, and the rest of the stomach is still in the abdominal cavity. So here you will have your diaphragm. So the GE junction is kind of at the normal position. So GE junction, this is kind of at the normal position. But what is the problem? A part of the stomach has rolled up. This was not supposed to be over here, right? This was supposed to be below the diaphragm, but it has rolled up and it has gone up. That is why it is called as a rolling or a paraesophageal, because it is going just adjacent to the esophagus. It is called as a paraesophageal hiatus hernia. Okay, I hope you get this point. Now if I ask you in the kind of a type 1 hiatus hernia, what is the association? So yes, I mean it is very obvious, because the GE junction is kind of moving proximally. Because of this, the lower esophageal sphincter will not function properly, and that is why the type 1 hiatus hernia is the one which is associated with the GERD, gastroesophageal reflux disease. On the other hand, the paraesophageal hernia, here the GE junction is the normal, so that is why there is no GERD in this particular patient. Okay, so that is the first thing which you need to understand between the type 1, that is sliding, and the type 2, that is rolling or the paraesophageal hiatus hernia. At the same time, now let us kind of zoom in on the rolling or the paraesophageal hiatus hernia. So here you have a part of the stomach which is going up like this, right? And what did I tell you? That there is a diaphragm which is still present over here. So don't you think that this part of the stomach, okay, so please concentrate on this part of the stomach, this is going to be under like tension. Why? Because this is going to be pulled up into the thorax, and then the diaphragm is compressing and everything. So because of this, it is at a risk of ischemia. This can happen, and at the same time you get a linear ulcers in this part of the stomach. These are something which are called as a Cameron's ulcer. Okay, so now you know that Cameroons also, these are associated with the rolling or the paraesophageal hiatus hernia. These are not associated with the sliding hiatus hernia. Okay, everything is clear. So because this is at the risk of the ischemia, so how will you manage this? If at all you have a rolling or the paraesophageal hiatus hernia, you have to go in for a surgery. And what is the surgery which you prefer in over here, guys? So here you have to go in for a fundoplication. Okay, so you have to bring this particular stomach down and then you have to go in for a fundoplication. Okay, I hope you get this point right. Okay, so this is the basics of the difference between the hiatus hernia, like the type 1 and the type 2 hiatus hernia. Cameroons ulcer, this is not associated with the sliding, this is associated with the rolling or the paraesophageal hiatus hernia. Now, investigation of choice for diagnosing a H type of the tracheoesophageal fistula. Now guys, what is a tracheoesophageal fistula? Nothing great about this. Here there is a communication between the trachea and the esophagus, right? That's what you mean by a tracheoesophageal fistula. Now there are various different types of the tracheoesophageal fistula. What you need to understand is that which is the kind of investigation of choice for the H type of the tracheoesophageal fistula. Now guys, this is a repeat question. This has already been asked in AIIMS and JIPMER like a couple of times. So you need to understand the answer is tracheobronchoscopy. So I'll just explain it to you what exactly is this and everything. Okay, so let's kind of talk about important points regarding the tracheoesophageal fistula. Now, if I just ask you, which is the most common type? Which is the most common type of tracheoesophageal fistula? Tracheoesophageal fistula. Okay, so the most common type is type C. What is happening in the type C? So in the type C, there is atresia of the upper part of the esophagus. On the other hand, the lower part of the esophagus is communicating with the trachea. This is what is referred to as a type C, and this is the most common variety of the tracheoesophageal fistula. Okay, I hope you got this. The most common type is the type C, and this is what is referred to as a type C, right? Now, what we are talking about, the H type of the tracheoesophageal fistula, that is what is a type E. Okay, there is a type E. So what is this type E? Here, the esophagus is communicating with each other, and there is a bridge which is communicating the esophagus with the trachea as well. So this gives rise to an H shape. Okay, are you able to appreciate it? So this is what is called as the H-shaped tracheoesophageal fistula, and this is what is a type E. And what I'm trying to ask you, what is an investigation of choice for this? Investigation of choice for this is a tracheobronchoscopy. It is a tracheobronchoscopy. Okay, what is the answer? It is a tracheobronchoscopy. On the other hand, if you just talk about this type C, here it is going to be a kind of a CT scan with the dye study. This is what is a kind of a investigation of choice for the type C tracheoesophageal fistula. Here you will use a low osmolar or a water soluble kind of a contrast in the dye. You will basically use a low or like a low osmolar contrast, and at the same time, if at all somebody asks you what is the best contrast, the best contrast will be barium, but that is not something which is preferred. The preferred one is a water soluble contrast. Okay, I hope you get this point. Now moving on to the next question, guys. Distended abdomen. So if at all, let's say that you examine a patient of an intestinal obstruction. Okay, so let's say you go to the casualty, and in the casualty, let's say there is a patient who is coming to you not able to pass the stool for like last 7 days or 5 days or something. Okay, so let's say there is no passage of stool for, let's say, last 5 days. Okay, let's say if at all this this is the thing. If you go and you examine this particular patient, okay, if you examine this particular patient, what will you find? You will find that there is an abdominal distension. Now what I'm trying to ask you over here is that what is the main cause of the abdominal distension? The distended abdomen in the intestinal obstruction, that is mainly due to what? Is it due to the diffusion of the gas from the blood? Is it because of the fermentation of the residual food? Is it bacterial action, or is it a swallowed air? Now, if you say that the answer is the swallowed air, you are absolutely correct, guys. Now, what is happening in this particular patient? Let's assume that this is a patient who is suffering from a intestinal obstruction. So let's say if at all there is a patient who is having an intestinal obstruction, what is going to happen? This part of the intestine, and there is some obstruction which the body cannot kind of overcome, and because of this the fluid accumulating into this particular lumen, it is kind of distending up. Now, as we talk, as we do anything, we have the swallowed air. Swallowed air. So air is kind of time we talk, you know, we kind of swallow food or everything. So some amount of the air is kind of swallowed. And this swallowed air is the one which is forming the majority of the volume of this distended intestine. Okay, you need to understand, you need to remember this. No doubt there is going to be the intestine secretions and all those stuff, but the swallowed air, this is forming the majority of the part of the distended bowel. Okay, I hope you get this point. Please remember why this is important. Okay, so if at all this is present, what you will do? Okay, so let's say if at all you are a casualty resident, you basically go, there is a patient with an intestinal obstruction. What is the first thing you will do? One of the first things you will do is that you will pass the nasogastric tube. So because if you pass a nasogastric tube, how it will help you? It will basically help you in decompressing the abdomen. Okay, this will basically decompress the abdomen, right? So it will basically get rid of those fluids, it will get rid of the air, and this will end up decompressing the abdomen. And because of this, the bowel wall will not undergo the ischemic changes. And that is the primary thing which you need to do as a surgeon whenever you encounter a patient as of an intestinal obstruction. Along with this, definitely you will start the patients on the IV fluids, because the patient has already lot of kind of dehydration. The patient would be in the state of dehydration because of the vomiting and everything. So yeah, you have to start the IV fluids as well. Right, moving on. So in case of a newborn, the commonest cause of an intestinal obstruction. So what is the commonest cause of an intestinal obstruction? Is it like a annular pancreas, duodenal atresia, jejunal atresia, or the esophageal atresia? So okay, it's pretty simple guys, it is the duodenal atresia. The commonest cause of an intestinal obstruction in a newborn, it is a duodenal atresia. Now, annular pancreas, that is also one of the important causes of a intestinal obstruction in the newborn. So let us kind of give you a clinical scenario. Okay, so let's say there is a newborn child, that is, let's say day one of life, and the patient is coming to you with vomiting, and the patient is basically the patient is coming to you with the vomiting. So you suspect that okay, the child might be having some intestinal obstruction or something. So you basically order an X-ray. On the X-ray, you basically get that there is a double bubble appearance. Okay, so you get a double bubble appearance. So what is the diagnosis, guys? What is the diagnosis of this particular patient? So vomiting with a double bubble appearance, what is the diagnosis? You cannot tell me. So there are two differential diagnoses of this. The two differential diagnoses is either can be a duodenal atresia or it can be an annular pancreas. Okay, so frankly speaking, these are the two differential diagnoses which you will have in this particular patient. How do you distinguish? This is based on the type of the vomiting. If at all the patient was having a bilious vomiting, then definitely the answer is it is a duodenal atresia. It's a duodenal atresia. But let's say if at all the patient is having a non-bilious vomiting, what is the answer? It is a annular pancreas. Okay, now guys, this is a very important concept which you need to understand. I'm sure you guys must be knowing it, but if at all you don't, please understand this. A child coming to you as a newborn, day one of life, coming to you with a vomiting, X-ray showing a double bubble appearance, do not get a kind of knee-jerk response and mark it as a duodenal atresia. No. If at all in the question they have given you a bilious vomiting, only then the answer is duodenal atresia. If at all they are mentioning it as a non-bilious vomiting, then the answer would be annular pancreas. Okay, I hope I have made myself clear over here. It is a very important concept. I hope you understood this. Now moving on, there is, let's say, a 50-year-old female who is admitted with an abdominal pain and anuria. This patient is having an abdominal pain and anuria. The radiological studies revealed that there is a bilateral impacted ureteric stone with hydronephrosis. Urine analysis showed the RBCs with the pus cells in the urine. Serum creatinine level was 16 mg per deciliter. The urea levels and the urea levels was 200 millimoles per liter. Which of the following should be an immediate treatment of this particular patient? Will you go in for a hemodialysis, DJ kind of stent drainage, lithotripsy, or ureteroscopic retrieval of the stone? What do you think, guys? What is the next step in the management of this particular patient? Right? So what should be your immediate treatment, guys? So here there is a patient who is having an impacted ureteral stone, and then the back pressure changes are there, the creatinine is elevated, urea is elevated and everything. Here you will have to go in for a DJ stent insertion. So what you need to go in for? You need to go in for a DJ stent insertion. Now, you might argue that why not just go and retrieve the stone? First and foremost, you have to look at the creatinine and you have to look at the urea. The patient will not be fit for the anesthesia. So this is not done. There are two reasons for this. First, the patient is not fit for anesthesia, and at the same time, let's say even if you kind of somehow make the patient fit and you try to go in for this or something, what might happen? You are having an impacted stone. What are you having? You're having an impacted stone. So if at all you try to go in for an impacted stone, you might land up into ureteral injury. Ureteral injury might happen because the patient is having an impacted stone. So always it is wise to first put a DJ stent. Okay, so what is this? This is a double J stent. It has a kind of a curved lumen at the end. So this is basically a patent stent which you basically put. The one end of this basically goes into the pelvis, the renal pelvis, and the other end is in the bladder. So this, what will this do? This will basically decompress the pelvic axial system, and over a period of time your creatinine and your urea will normalize. And once it gets normalized, now you can basically plan an intervention and you can basically operate on this particular patient. Okay, I hope you got this point. This is how you'll manage a patient if at all you have an impacted stone. Right, I hope I've made myself clear. Moving on, guys. Now this is a image based question. Now what I'm trying to ask you is, guys, what is the diagnosis? So is this patient suffering from a ADPKD, ARPKD, crossed fused ectopia, or the horseshoe kidney? What do you think, guys? What is the answer to this particular question? So I'll just zoom into the image, guys. What do you think? What is the diagnosis of this particular patient? Now, if at all you say that this is a patient who is suffering from a horseshoe kidney, you are correct, guys. You are absolutely correct. Why this is a patient who is suffering from a horseshoe kidney? Okay, so as you can see over here, guys, I hope you're able to appreciate that there is a renal shadow which is present over here. I am trying to jot it down for you guys. I hope you are able to appreciate it. This is a kind of a renal shadow, and you can see that the lower poles are basically going and meeting each other. Even if you look at these lower pelvis, they are basically directed towards each other and they are kind of meeting in the middle. So this basically gives you the diagnosis of a horseshoe kidney, guys. Okay. Now, guys, this is an important image. You should be able to appreciate a horseshoe kidney, right? So okay, so this is a contrast enhanced image. You can see that the lower pole calyces are also basically going closer to each other. Okay, so no doubt the answer is a horseshoe kidney. So as we are on the topic of the horseshoe kidney, let us kind of revise a couple of points regarding it. Horseshoe kidney. Now, pretty simple. I'll just ask you some basic questions on this. So if I ask you guys, okay, so what is a horseshoe kidney? No doubt that the lower pole of the kidney is kind of fused together, and we know that the kidneys, they basically form in the pelvis and then they come to lie in the abdomen. Okay, this ask you the ascent, this particular ascent of the horseshoe kidney, this is restricted by what? So if I just ask you, this ascent is restricted by which vessel? So this ascent of this particular horseshoe kidney, this is restricted by the inferior mesenteric artery. Okay, please understand this, guys. It is a very, very important MCQ. This ascent of the horseshoe kidney, this is basically restricted by the inferior mesenteric artery. Now, if I ask you, what is the level at which the isthmus is lying? Isthmus of this particular horseshoe kidney, this is at what location, at what position do you have the isthmus? So isthmus is basically present at the level of L3, L4 vertebral level. Why? Because as I just told you that the inferior mesenteric artery is the one which is going to kind of restrict the ascent of this. So the origin of this inferior mesenteric artery is at the level of L2, L3, and that is why this particular isthmus, this lies at the level of L3, L4. Okay, so now this is something which you need to accurately know. Why? Because in the options you will get the options as L1, L2, L2, L3, L3, L4, L4, L5. So the answer is L3, L4. You got the reason why? Because the origin of this inferior mesenteric artery is at the level of L2, L3, and that is the reason why the isthmus is lying at the level of L3, L4. Okay, right? So these are the couple of points regarding the horseshoe kidney which are kind of important for you guys. Okay, I hope you got this. Now I have a patient who is like a middle-aged diabetic female. Okay, the patient has presented to you with a flank pain and the fever. On the USG examination, there is an irregular and like the kidney is irregular, and then there is a fat density lesion which is present with the calculi. Okay, so yeah, basically the patient is having signs of pyelonephritis in the background of a calculi, and the patient is diabetic. So what do you think, guys? What is the diagnosis of this particular patient? Is this particular patient suffering from a TB of the kidney, xanthogranulomatosis kidney, chronic pyelonephritis, or the renal abscess? Okay, what is this particular patient suffering from? Now, if you say that this is a patient who is suffering from a xanthogranulomatosis pyelonephritis, you are kind of correct. Okay, so let us kind of evaluate this, guys. Okay, so what is happening over here? There is a patient who is coming to you. The patient is diabetic, okay, no doubt. But the main thing is patient is having a renal calculi. The patient is having a renal calculi. Okay, calculi. Now along with this, the patient is having the signs of pyelonephritis. So all these particular stuff, pyelonephritis. So patient is having all those things, like, you know, irregular kidney, then fat density, and all those stuff. Yeah, all those things are basically present in this particular patient. But the important thing is there is a fat density. So fat density, this is something which you basically tend to again point towards the xanthogranulomatous disease. Okay, so yeah, all these things basically point towards the diagnosis of a xanthogranulomatous pyelonephritis. Now I just ask you a couple of important questions from the xanthogranulomatosis pyelonephritis. What is the most common organism which is associated with xanthogranulomatosis pyelonephritis? Can you please guide me on this? So if you say that the most common organism which is associated with the xanthogranulomatosis pyelonephritis is Proteus, you are absolutely correct, guys. Okay, so what is the answer? It is a Proteus. Okay, I hope you get this one. Now, if I ask you what is the most common stone, what is the most common stone which is associated with xanthogranulomatosis pyelonephritis, again the answer would be a staghorn calculi. Okay, what is the answer? It is a staghorn calculi. So because of the enzyme kind of urease, you will get a formation of a xanthogranulomatosis, like a staghorn calculi. So if I just summarize to you guys, so what is happening over here? There is a patient who is having a kind of a staghorn calculi for a prolonged period of time, and the patient kind of did not got treatment for it, and because of this the patient ultimately landed up into a kidney infection, which ultimately became a xanthogranulomatosis pyelonephritis. Okay, so in the kind of a scenario in the background of the long-standing staghorn calculi, so in the background of a long-standing staghorn calculi, you are getting a pyelonephritis which is called as a xanthogranulomatosis pyelonephritis. Xanthogranulomatosis pyelonephritis. Okay, yep, right, as simple as that. Moving on. So let's say there is a 40-year-old kind of man who is suffering from the fever and the pain in the scrotum, which is not relieved by elevation of the testes. Okay, so there's a kind of a man who is suffering from the fever and the pain in the scrotum, which is not relieved by the elevation of the testes for 3 days before he had a kind of sexual contact with a young female. Okay, what is the diagnosis? So is this particular patient suffering from a testicular tumor, okay, acute epidermitis, torsion of the testes, or kind of a acute orchitis? What do you think? So okay, so just let's break it down. There is a man who is suffering from all those things, pain in the scrotum and everything, but the point which we need to note is that the pain is not relieved on the elevation of the testes. So this gives us a diagnosis of a torsion of the testes. So guys, whenever you have a patient who is coming to you with a painful scrotal swelling, you have two main differential diagnoses. So what are the main differential diagnoses? So you may have either a testicular torsion, or you may have an epididymoorchitis. Okay, so these two can be the kind of differential diagnosis. Now, to distinguish between these, what you perform something which is called as a French test. French test or French sign or whatever. You basically perform this. Now, what is this French sign? What you are basically doing in this French sign is that you are elevating the testes. Okay, if on elevating the testes, if at all the pain subsides, probably the kind of pain is relieved, probably the diagnosis is epididymitis. But if at all on elevation of the testes, if at all the pain is actually increasing, so if at all the pain is increasing, what is the diagnosis? The diagnosis is torsion of the testes. Okay, so please understand this. This is what is called the French sign or the French test or whatever. And yeah, this is how you will distinguish it. It is a very, very important kind of a test which you absolutely need to know. If you don't know this, please go back and read this. It is absolutely essential for you guys. French sign, French test, whatever, how to distinguish between testicular torsion and epididymitis. Now, what is the distal extent of the resection when you're performing a TURP? So I'm sure you guys must be knowing what is a TURP. In this, what you do, this is your prostatic urethra. You have the prostate which is just surrounding this prostatic urethra, and when you have, let's say, a BPH, a benign prostatic hyperplasia, you basically go inside and you peel off the chips of this particular prostate like this. So what this particular question is trying to ask you, the distal extent, till where you will kind of peel off these chips. What do you think? What is the answer to this particular question? Is it like a urogenital diaphragm? Is it verumontanum, bulbourethra, or the bulbourethral gland, whatever? So guys, if you say that the answer to this particular question is in fact a verumontanum, you are kind of correct. So answer is verumontanum. Now why? Now, okay, so why are you performing a TURP? Why are you performing a TURP? TURP is basically being performed for a benign prostatic hyperplasia. So what is the main problem in the benign prostatic hyperplasia? In this, the patient is not able to void. Okay, so patient is not able to void properly, and that is what is the problem in the kind of a BPH. So what will you expect, guys? Like after TURP, okay, so you basically want that post TURP, you want that patient should be continent. So the patient will be continent. For this you have to, okay, for this you have to preserve your external urethral sphincter. Okay, so for this, what do you want? You want to preserve the external urethral sphincter. So if I just ask you guys, what is the position of the external urethral sphincter? So okay, so what I'm basically drawing in over here is that this is your, okay, I'll just tell you what exactly all of these are. So this is your bladder, definitely. This is your prostatic urethra. This is your membranous urethra. Surrounding the membranous urethra, you have your urogenital diaphragm. This is your bulbar, and this is your penile urethra, right? So this is what you have. If I ask you guys, what is the position of an external urethral sphincter? And if you say that it is alongside this membranous urethra, you are absolutely correct, guys. Okay, what is this? This is the position of an external urethral sphincter. This is what you get. Now if I just ask you, as we just discussed, if we want the patient to be continent post surgery, you want to kind of preserve the external urethral sphincter. But is there any placard, is there any board which is present at the external urethral sphincter? No, guys. I mean, when you basically perform a TURP, everything looks like a lumen to you. You cannot appreciate that I am in the prostatic urethra, I am in the membranous urethra. You cannot say that. Okay, everything looks kind of similar. So we don't have that. But you know, thankfully, what do we have? We have a verumontanum. So verumontanum is a kind of a volcano-like projection which is present in the prostatic urethra. This is what is called as a verumontanum. So what is the importance of this verumontanum? That the ejaculatory duct is kind of opening over here. Okay, now that's not important. The important is we can appreciate this verumontanum. So if I say you that you perform a TURP and you restrict your dissection just proximal to this verumontanum. Okay, so if at all I ask you to perform a TURP and I say you that you should not go beyond the verumontanum. In other words, I'm saying that okay, if you don't go beyond the verumontanum, you are kind of sure that the external urethral sphincter is kind of protected. So I hope you got this point. This is the reason why the distal extent of resection while performing a TURP, it is verumontanum. You should not go beyond the verumontanum in order to, like when you're basically performing a TURP. Okay, yeah, I hope you got this right. Okay, now let's move on and let's talk about the bladder carcinoma. So what I'm trying to ask you over here is that what is the best intravesical chemotherapeutic agent used in the management of a bladder tumor? Okay, so best intravesical, that is fine, chemotherapeutic agent for a bladder carcinoma. The answer is it is mitomycin C, guys. Okay, it is a mitomycin C. It is not BCG. Please understand this. It is not BCG. So let us understand this. Okay, so let's say if at all there is a patient who is having a bladder carcinoma. So here you go in for a intravesical treatment. You go in for an intravesical treatment. Why? Why? Because to prevent the recurrence post TURBT. So you need to appreciate that whenever there is a patient with a bladder carcinoma, the primary treatment is TURBT. TUC, then doxorubicin, thiotepa, and all those, right? I hope you get this point. Now if I ask you which is the best overall, okay, if I ask you which is the best intravesical agent overall, no doubt BCG, this is best overall. But you need to understand that this is a immunotherapeutic agent. It is not a chemotherapeutic agent. Okay, so BCG is the best overall immunotherapeutic agent. But what I'm trying to ask over here, what did the question ask you? What is the best intravesical chemotherapeutic agent? So the best intravesical chemotherapeutic agent, it is a mitomycin C. Okay, I hope you got this. Because the question had mentioned chemotherapeutic agent, that is why the answer is mitomycin C. Right. Okay guys, now moving on. So let's say there is an 85-year-old man who is coming to you, who went in basically a TURP, and basically he was found to have a adenocarcinoma of the prostate. Okay, so so what is happening over here? There is a man, like 85-year-old man, and he went in for a TURP. Okay, he was unaware of anything. He just had like some signs and symptoms of BPH. So you went ahead and you did a TURP in this particular patient, and post surgery, when you did a histopathological examination, in this you found that the patient is suffering from the carcinoma prostate. So what I'm trying to ask you, if at all this is a scenario, what will be the management? Will you go in for endocrine therapy, radical surgery, hormonal therapy, or no further treatment? Now, okay, so just look at this particular scenario. 85-year-old man, TURP, patient suffered from a prostatic carcinoma. What is the further line of management? So answer is no further treatment. Why? Why the answer is no further treatment, guys? Because you need to understand, let's say there is a person who gets a carcinoma prostate today. So let's say there is a person who is getting a carcinoma prostate, let's say today. So even if he gets no treatment, even if he has no treatment, then he will not die in next 10 years. I understand my point. So the point which I'm trying to make over here is that even if there is a patient who is having a carcinoma prostate, even if you don't treat it, the patient is unlikely to die because of the carcinoma prostate in the next 10 years. Okay, so if you understand this, if it means that the carcinoma prostate is a bit indolent tumor, so if you understand this, so now you will understand the management of the carcinoma prostate. So whenever you have a carcinoma prostate, what you basically do, you divide the patients into two groups. If at all the patient is less than 70 years, or the patient is having the life expectancy of more than 10 years. And on the other hand, you have a patient who is kind of more than 70 years of age, and or the patient is having the life expectancy of less than 10 years. Okay, so if at all the patient is having a life expectancy of less than 10 years, is it justifiable for you to kind of subject this particular patient for a radical prostatectomy? It is a very morbid surgery, so no, it is not justifiable. So here, or you need to go in for an observation, because before the patient dies because of the prostatic carcinoma, some or the other disease is going to kill him. So if we just go back to this particular patient, he is already 85 years, so you know, he's unlikely to die because of the prostatic carcinoma. Most chances of him dying because of a stroke or a MI or something like that. So why do you want to trouble this particular patient with a radical prostatectomy? Don't do that. Just go in for an observation. On the other hand, if at all the life expectancy is more than 10 years, or if at all the age of the patient is less than 70 years, no doubt here you have to go in for a kind of a radical prostatectomy. So here you have to go in for a radical prostatectomy. Okay, so here you have to go in for a radical prostatectomy. Okay, I hope you got this point. Right, moving on. So what is the investigation of choice to diagnose an undescended testis? So let's say there is a kind of a female who is bringing the child. Okay, so let's say the child has been brought to you by the mother, and the child is having an empty scrotum. So you are, let's say, a pediatric surgeon. What you need to do is that right, so somebody is asking, okay, so okay, I'll just kind of clear the kind of doubt. So before I talk about this, so yeah, Siddharth is asking PSA antigen follow-up. No, not really. See, understand, PSA antigen per se, it is invariable, right? You know, it really doesn't mean anything. Like, there are around 40% of the patients who are actually having a prostatic carcinoma, they have a PSA which is less than 4. So what I'm trying to tell you, no matter how treatable the prostatic carcinoma is, no matter how aggressive the prostatic carcinoma is, the patient is unlikely to die because of it. Okay, you might give the patient a palliative treatment. You will definitely give the patient a palliative treatment. Let's say if at all the patient develops a urethral obstruction, you might give a urethral stent or something like that. You will give the palliative treatment, but you will not go in for therapy. You will not go in for a castration. You will not do that. Okay, so yeah, it is not advisable to go for that. Yeah, I hope you got this point. PSA per se, it is kind of invaluable in the prostatic carcinoma today, right? I hope you get this point. Moving on. So guys, yeah, let's say the patient is having the empty scrotum. What you will do, you will first try to palpate the testes. Palpate the testes. You might find this particular testes in the kind of inguinal canal. Okay, so if you are able to palpate in inguinal canal, great. Just go in for an exploration. But let's say if at all it is non-palpable. Okay, if at all it is non-palpable, then what you will do? So what I'm trying to ask you is that if at all there is a non-palpable testes, what is the investigation of choice? So please understand, guys, the investigation of choice for this is a diagnostic laparoscopy. You will have to go in for a diagnostic laparoscopy. You'll have to put your kind of scope inside the abdomen and you will try to find the testes. But how will you find the testes, guys? I mean, such a kind of big abdomen. So once you perform the kind of a laparoscopy, you should follow the testicular artery. Now what you know, wherever the artery, like wherever the organ is going, it will take the blood supply along with it. So you follow the testicular artery and this will basically take you to the testes. Okay, this is going to take you to the testes. I hope you get this point, right? So if at all there is option of a testicular artery and the vas difference, okay, so you can either follow a testicular artery or you can either follow a vas difference. But if at all you have both in the option, you have testicular artery as well as the vas difference, it is always advisable to go in for a testicular artery. That is more reliable of a indicator, right? So the whole point is investigation of choice is a diagnostic laparoscopy. Moving back, the most common wrong answer which I usually get is an MRI. Okay, so you think that okay, testes is a kind of a soft tissue, MRI is kind of best for the soft tissue, let's mark MRI. That is not correct. Okay, it is really not correct. Please don't mark it. The answer is C, that is a diagnostic laparoscopy. Okay, so I hope I have made myself clear. Investigation of choice for undescended testes, no doubt it is a diagnostic laparoscopy. Now this brings us to the last question of the day, guys. There is a couple who is married since 3 years, and the kind of couple is trying to conceive for like last 2 years but with no results. On semen examination, the patient had a reduced seminal volume and azoospermia. On the PR examination, the seminal vesicle was palpable. What is the definitive treatment of this for this particular patient? So let us kind of break down this particular question, guys. So here what do you have? Here you have a couple who is basically having a primary infertility. Okay, married since 3 years, not able to kind of get the child since like 2 years. So patient is having a primary infertility. Okay, now okay, so obviously you will go in for an evaluation. So you basically went in for the evaluation of the man. The findings are available. So the man had basically a reduced seminal volume, reduced seminal volume. Now before this, we need to understand how the kind of the seminal fluid is secreted. So what do you have? You have the testes, and then you have your epididymis, and then you have the vas deferens. The vas deferens is basically joined by the duct for the seminal vesicle, and when it is kind of joined, it forms the ejaculatory duct, and this ejaculatory duct is kind of opening into your prostatic urethra. Okay, so I've kind of exaggerated this just for you to understand, but yeah, I mean, yeah, it is not proportional diagram, but yeah, I hope you get this. So this is what is a testes, this is your epididymis, this is your vas deferens, this is your ejaculatory duct, this is your seminal vesicle, right? I hope you get this. And this is basically opening at the verumontanum. We just saw the verumontanum a couple of minutes back. So yeah, that is what is a verumontanum. So this is what is a pathway of the sperm. Now, if I ask you normally, like if at all I come to you, if you are a man, if I come to you and I perform a PR examination in you, will I be able to palpate a seminal vesicle? Probably not. So what you need to understand is that normally seminal vesicle, it is not palpable. It is not palpable. Are you understanding my point? It is not palpable. It can be palpable, let's say if at all there is an obstruction to the seminal vesicle duct, or let's say there is an obstruction to the ejaculatory duct. If at all this is happening, then definitely this seminal vesicle is going to get bigger, and now you will be able to palpate it. Are you able to understand it? So normally the seminal vesicle is not palpable, but in this particular scenario, what happened when you performed a PR examination in this particular man, the seminal vesicle was palpable. So okay, so first of all, he had a reduced seminal volume. At the same time, he had a palpable seminal vesicle. So don't you think it is kind of pointing towards the diagnosis of an ejaculatory duct obstruction? Yeah, so ejaculatory duct blockage or ejaculatory duct obstruction. So if at all this is the thing, what is the definitive treatment? Now this particular question is trying to ask you what is the definitive treatment. So if I'll just kind of deviate a bit, if at all this question would have asked what is the next step, okay, if at all this question would have asked next step, you would have performed a truss, that is a transrectal USG. So if at all you get these findings, you suspect that the patient is suffering from ejaculatory duct obstruction, you perform a truss, that is a transrectal USG. This will help you make the diagnosis of an ejaculatory duct obstruction. Yeah, and once this is kind of made, then you can basically go in for the treatment. And what can be the treatment for this, guys? The treatment for this is TURED. What is this TURED? It is transurethral resection of ejaculatory duct. Do you get this point? So the treatment is TURED, that is a transurethral resection of an ejaculatory duct. Okay, I hope you get this point. So here the patient is suffering from a ejaculatory duct obstruction. So what you can basically do, you can go through the transurethral route and you can just resect this kind of ejaculatory duct, and that is what you call as a turret. Right, so that's it guys, that's all for today. I hope you enjoyed this particular session. I hope it added some value to your life. Thank you so much for joining with me guys. It was indeed a pleasure interacting with all of you. Yeah, it was indeed. Thank you so much. Right, so yeah, if you have anything to ask me, if you have any doubts, please do ask me. I'll be more than happy to kind of connect with you. Right, I'll be more than happy to kind of guide you over this. Right, so right, so thank you so much guys, it was indeed a pleasure. And yeah, if you kind of like this particular session, if you like these particular MCQ discussions with me, and if at all you want more of it, so I'm coming up with a revision course in surgery. Okay, it will be 44 hours, and in this the entire surgery will be taught system wise. And the great part is it is going to be an MCQ discussion session. So like all the sessions will be MCQ based. I'll be putting up the MCQ and you will be basically, I'll be basically putting up the MCQs and everything. So entire general surgery will be revised in the form of the MCQs. If at all you are remotely interested into this, you can definitely go and check it out on my profile. It is there on the Plus platform. If you are a Plus subscribers, please don't miss it. I'm sure it is going to be very, very helpful for your upcoming NEET exam. If you're not, and if you're remotely interested into joining it, you can definitely kind of subscribe to the Plus platform. If you wish, you can use my promo code, that is tr.pawan. Right, so thank you so much guys, it was indeed a pleasure interacting with you. See you tomorrow again. So the next session which I'm going to have is going to be the tomorrow, so again at 9 a.m. and 10 a.m. So tomorrow at 9 a.m. and 10 a.m. we are again going to have the kind of a session. So yeah, I hope to see you guys over there again. Thank you so much, it was indeed a pleasure interacting with you. Have a great day, happy studying. See you, bye.